So two important issues which we are going to discuss in this panel is self-preservation and how well do doctors know their patients. And we have an amazing panelists in this session. Next slide. So we have Dr. Shailendra Rajput, who is a consultant pediatrician, diabetes and endocrine lead, and Royal College tutor for children's services at, I think some spelling mistake is there. He is working in UK as a pediatrician, especially in the field of diabetes and endocrinology. Next slide. Dr. Sarita Bajaj, we all endocrinologists know her so well. She is a senior endocrinologist, director, professor, and head of medicine at MLN Medical College, Prayagraj, president of RSSTI, and lot of accreditations to her name. Next slide, please. Dr. Sandeep Julka, we already saw his introduction, endocrinologist from Indore. And I would actually like a quick introduction from each of them again. Before they start the session, I would like them to talk about themselves. Next slide. Dr. Renu Chawla, I know her because she was my senior at Jabalpur, and now she is practicing internal medicine at Bellevue, Seattle. We will get to know more about her and her philosophy of care while we talk to her. Next slide. Dr. Sunita Deshmukh, she is from Pune, BJ Medical College. She's a geriatrician practicing internal medicine in Portland, Oregon for last 20 years. And she's also trained as palliative care provider. Next slide. Okay, so these are the panelists. I'll hand over the session to Dr. Sandeep, and I would want each of you to introduce while you start speaking, so that we understand a little bit about yourself before we understand about your patients and how well you know your patients.
Namaste once again, and welcome to all the audiences and the co-panelists. And I think we'll start with Professor Dr. Sarita, madam. I think opening comments from you and your introduction, madam, and then we'll pass on to Dr. Sunita, and then Dr. Renu, and then Dr. Shailendra, and in the last, I'll just say a few words about myself. Madam, kindly unmute yourself.
Yeah, I've done that. I've done that.
Yeah.
So a very, very good evening to everyone. It's a pleasure to be part of this panel, self-preservation, and how well do we know our patients. I'm an endocrinologist based out of Allahabad. I was heading the Department of Medicine till almost a year back, and my passion is education. And of course, we've had a lot of residents with us. In a government setup, we have a different set of patients whom we cater to. I'm passionate about women's health, thyroid disorders, growth disorders, and I've done a lot of work on women's health as part of a lot of societies. So it's a pleasure to be here. Thank you, Beena. Thank you for organizing this and for to be part of this meeting. Thank you. Thank you so much.
Thank you very much, ma'am. Dr. Sunita, let's hear from you.
Yeah, hi. Thank you so much for giving me this opportunity. I'm so delighted to be here with you all. And good evening to all of you. My name is Sunita. I'm internal medicine working out of Portland, and my passion is about delivering the complex care management for our very sick people as a whole person, but integrating the principles of palliative care to make the life easier for the patients as well as their families. That's what we are currently focusing on, developing the plans, how to help our group have a comprehensive plan so we can do it, because there are not many palliative care doctors, but we have to all learn some of the tools. Thank you.
Thank you so much. Dr. Renu.
Hello, good morning Sunita, and good evening to you all. My name is Renu. I am an internal medicine physician. I am in Seattle area in Washington. Thank you for inviting me to join this. I'm extremely excited to be a part of this. This is the first time I'm doing something like this, so we'll see how this goes and looking forward to more opportunities like this. I primarily focus on primary care delivery. My patient panel can be from 18 years old to as older as they can get. I focus on preventive care and treat a person as a whole. I want to be an advocate in helping them make right decision and choices. So that has been my main focus. I specifically like working with older individuals, even though I'm not a geriatrician, but there's a lot of geriatric side to my practice. And I also focus on perimenopause, menopausal women, and dealing, specific issues that they have during that time. So looking forward to this discussion. Thank you, Beena, for inviting us, and great to meet you all.
Thank you, Dr. Renu. Dr. Shailendra.
Greetings, everyone. I'm grateful to be a part of this panel, and thank you very much for inviting me to join. I'm Shailendra Rajput. I'm a consultant pediatrician at Macclesfield Hospital in UK, and my special interests are in diabetes and endocrinology. I've recently also taken some educational roles, and I've been appointed as a Royal College tutor for pediatric tradies. Thank you.
So thank you very much. I am Dr. Sandeep Julka, and you would have heard that video in the initial part of our conference. We made that video for doctor-patient role and relationship. I just love seeing patients, and that is what draws me to this profession. Now let us go straight to discuss the two very important and very pertinent questions. One is about self-preservation, and the second is how well do we know our patients. Now, while just studying about self-preservation, it was a new topic for me, although I think I practice everything what needs to be done there. I came across a statement that the heart must first pump blood into itself. The heart must first pump blood into itself, and that is when it then works tirelessly all through your life and then takes care of everything else. So we as physicians are the heart of the society, and we need to be healthy. That is probably one way of looking at self-preservation. And then there is a lot of talks on healers, heal thyself, where we want our physicians to be healthy, both all mental, physical, and spiritual health. There are some disturbing statistics that the suicide rate is twice as much in doctors versus the general population. And we also know that unconditional allegiance to our profession can lead to challenges. Hard work and long working hours are applauded. That also leads to a lot of problem. And when the panelists said good morning and good evening at the same time, so you all know that our panelists are across the world. There is good morning, good afternoon, and there is good evening. So our panelists are empowered, they are eminent, and I'm sure they're going to make it very, very easy. So there are 3 E's. And I'm sure, as I stated about doctor-patient relationship, talking about self-preservation, I really wish somebody spoke to me 25 years back when I started my practice. So going straight away, let us start. And I'm sure we will all realize, while the initial part of discussion will be self-preservation, the second part of discussion on how well we know our patients will have different connotation, because in India there is sheer number of patients. As we were discussing prior to this in one of our meetings, that probably a physician would see something like 15 patients in say 2 hours, whereas somebody who is in the Western hemisphere will see 15 patients in a day. So we'll have 2 different perspectives, and I'm sure we will address to all the audience in either side of the say, Atlantic, so to speak. So let us first start with Professor Dr. Sarita Bajaj, madam. You are a real treasure of knowledge and how to deal with self-preservation. So my first question would be, is it taught in medical colleges? Now, it wasn't taught when I was there in early 90s. Is it taught now? And if not, is it only the professors such as yourself who introduce this subject to the students? And if not, then what should be the curricula, or how should it be introduced to the doctors practicing now, ma'am?
Yeah, it is being taught now. Sandeep, if you go back when they started, the entrance exam for the postgraduate courses, right? At that time, it should have been implemented. See, there are two purposes of this sort of interaction, what you're talking about, or this teaching of self-preservation, which is part of an interaction. See, when I did my MD, so I did my MBBS, then I knew which subject I wanted to take up, and it was based on the marks. So if you have a good score, then you get into the subject of your choice. The principle here is same, but you may not necessarily get back into the same medical college that you were in as an undergrad, right? You would see where you've gotten as an undergrad, that's a prestigious college. You want to continue your post-graduation there. And of course, sometimes we do not have the facility for a super course, for a DM course, then you have to choose another college. So a lot of times our residents do not recognize us. So the first important part of an interaction with the residents is for them to be aware of the entire faculty in the medical college. So keeping that in mind, when I took over as head, I said nothing doing. As soon as the first year residents come in, we sit down with them over 2 days, and we explain not only about the faculty, about the working of the college, and ours is like satellite buildings in different places. So as to where they are located. In a government setup, you'd set 15. I'm saying 500. A busy OPD can go beyond 500. Like in my husband's OPD in the hospital before he retired, because he just couldn't cope up with the numbers. There were over 500 patients in one day. And one working day, I mean, from say 8 o'clock in the morning to 4 o'clock in the evening. So, I mean, of course, he had some residents helping him. So when I'm talking of numbers, in a medicine OPD, it goes up to 5,000 patients. Of course, we have different clinicians, sitting in different rooms with residents helping us. So every OPD does not have an attendant to let the patient in. So you have patients crowding around you. You're trying to help them, address them, talk to them, understand them, explain to them. So you can imagine how much time we're able to spend with them. So this concept of self-preservation as to, I liked what you mentioned, like alert. I think that was the acronym you had come up with, no? So you have to, how do we acknowledge their presence? Be able to listen to them, explain to them, then recall. And then of course, thank you for coming to show me. And of course, if by choice, the patient will be allotted to a particular OPD, or they go to any OPD depending on whatever they have requested when the OPD slip is made. The OPD slip, just 1 rupee. I mean, what is, can you imagine so that's why just 1 rupee, and recently they increased it to 10 rupees. So you can just imagine, obviously considering the numbers, So, well, those are government rules anyway. We don't have nothing to do about that. So self-preservation in the OPD is important. If we are, like because somebody would say, "Mera number pehle, mera number piche, mujhe jaldi kar diya, mujhe jaldi kyun nahi kiya, usko pehle dekh liya, I'm more sick." Like, how do you overcome those challenges? So you have to keep the tempers down, and sometimes there's no electricity, or pankha bhi nahi chal raha. You forget about even in cooler or an air conditioner. In summers in the northern part of India, at least Prayagraj, Allahabad, like it's hot, it's really hot and humid. So you're trying to battle just about everything, the surroundings, the patients, and it is difficult. It is difficult. So unless you keep your cool, the residents will not be able to do so. So this is in the OPD setup. Similarly, indoors, at least where the emergency setup is, sick patients. We are dealing with sick patients, really sick patients. Again, we do not have any guards to prevent the attendants from coming in. And sometimes one patient has 10, 15, 20. So in a 20-bedded ward, if you have 1,000 people around you trying to work, it's very difficult. So I'm sure you've heard about the violence against doctors, against junior doctors, against senior doctors. So that's partly responsible when you are surrounded by so many people and they're not, you're trying to get the patient, to revive the patient, to get the IV line going, to get the RAS tube in, et cetera, et cetera. So at least in a government setup, it's difficult. But what we try to do is go again by the ABC formula. So it's A is your appearance. The apron. I'm glad you're wearing an apron here right now. So we tell them, yes, you need to wear an apron. And it should mention whether you're a resident, senior doctor. We do not, initially we were having the names as well. But then, like the violence became so much that, like they're targeting doctors by name. So that was a bit disappointing. So the appearance. Decently dressed, wearing an apron will at least identify you as a healthcare provider. Your behavior. Try not to lose your temper. Just answer, talk, explain, and then address the issues. But the emergency management has to be immediate and make sure the patient's relatives are aware of that. C is for, it can be capability, competence, compassion, courteous, how considerable you are, your confidence, and then you should be committed as well. So the capability is, I would keep it last. So your appearance, your behavior, and the other points which I just mentioned. And D is for your dedication, your devotion, and your, like the duty, your duty hours. You come on time, and make sure you give a proper charge to the next resident who is going to be taking over. That's very, very important to get the message across. And be courteous to the paramedics as well. That's very important. And of course, earnest, you have to be earnest and make sure, because in a government setup, you have to consider all the economics. Like I'm saying, if it's 1 rupee for an OPD slip, so we try as far as possible to at least provide the essential medicines, but some things they have to be purchased. And healthcare insurance, most of our patients would not have, not in a government sector. So, this is what I would like to say right now.
Thank you so much, ma'am. You've actually brought out the challenges which we have, but I'm sure we'll have some answers to what can be done to overcome those challenges. My next question would be to Dr. Renu. I'd like to bring you in, ma'am. That what in your view is self-preservation, and how can it prevent burnout and compassion fatigue? So what is it, and what can be done to prevent burnout?
Thank you for that question. I can only, after listening to Sarita ma'am, I'm totally amazed. I mean, where I and Sunita practice, it is very different. We clearly, I was going down the memory lane of when we were doing internship in India, how different it was. I moved right after that. So clearly, I mean, I talked to my colleagues and friends in India, but this really brought rigors into me as to what the situation and what daily challenges that you face as a physician in India. So really my heart is very warm. The things that I think what leads to our burnout is mainly when burnout happens, it leads to a lot of medical errors. It leads to personal, professional dissatisfaction. Patients are dissatisfied. Clearly, our judgment is affected. And the more stress is on us, this leads to the path of failure or burnout. In day-to-day in medical life, we face challenges as, we look at illness, people who are in pain, people who are in suffering. We deal with death every day. And then on top of that, we have scared or angry family members. It leads to clearly physical, emotional, and spiritual imbalance. So if as a physician, we do not know how to deal with this, we can have physical symptoms as dissatisfaction, exhaustion, probably disrupted sleep. That sets the ground for chronic illness just amongst ourselves, like hypertension or perhaps diabetes, or even we can develop heart disease. And I mean, I can just mention more and more things that happen. Of course, it leads to more irritability or anxiety, more depression. But clearly, we know that a lot of physicians are indulging into alcohol as their savior. And so there's increased use of alcohol or substance abuse. And not to mention, I mean, it was mentioned already, it leads to increased suicide, even though it is undercounted and underreported. But we all know that there's a huge increase in suicides amongst physicians. We've all known people who have had massive fatal heart attacks, and it's all stress driven. I think part of this comes from, of course, the situation. The work situation is extremely important, and Sarita ma'am explained the scenario that she faces day to day. But a lot of it could be our personal traits too. Our personal traits, like I might be micromanaging every situation. I want to basically resolve every problem that my patient is facing. I do not know how to say no. I do not know how to detach myself. I want to become emotionally involved. And when that happens, it leads to just stress and distress in me. I kind of, in my day-to-day, if I have a limited time with the patient, I am distressed because I get drawn into their emotions. Then I put a mask and move on to my next patient, and so on and so forth. When that happens, of course, I have this unprocessed emotions at the end of the day. I have not been able to detach myself, and then we all go home to a full life of family with kids and other responsibilities. So here we're already setting the ground for burnout. Similarly, if we're not taking care of how to manage our mental health, it just adds on to poor judgment, and eventually the work becomes work rather than a commitment. I mean, you do it just because you're committed to it, but there's no internal satisfaction. So a few things that we know can help. This is where self-preservation comes in. So in self-preservation, I mean, we can definitely have a full session about that, but I think I want to make 2 points over here. One will be how to do self-care, and one will be how to detach yourself. The 4 foundation of self-care could be taking care of yourself, which can involve finding time to meditate or do mindful practice. Make sure that you eat healthily, exercise regularly, and try to get about 7 to 8 hours of sleep if you can. It's easier said than done. People can have other involve into some kind of hobbies, do reflective writings, talk to your peers so that you're not alone in this, and perhaps even talk to a therapist. So those are some ways of doing self-care. So self-care is extremely important. And I want to really focus on detaching ourselves. What happens is there are 2 kinds of empathies. One empathy is that we all have, which is most common, is an emotional empathy. If you have an emotional empathy, you actually feel the pain of the patient and you perceive it at the same level, which is distressful. That actually impacts your judgment when making medical decisions. I was reading about cognitive empathy, and that's probably cognitive empathy is that you see the situation from patient's perspective, you feel their pain, but you're not involving yourself to the point where it is causing distress. You can almost stand out and judging what good they are going through, then you make more objective decisions. So it's almost like emotional detachment, but with then present empathy. So I think that really helps with the objectivity. So if we can focus on detaching ourselves, learning how to say no, knowing the boundaries, and then focusing on self-care can help with self-preservation. So if we can take a couple bits and pieces from this, and at the end of the day, practice this, I think there will be some, self-preservation that will be left at the end of the day to move on to the next day with more success and more desire.
Thank you so much. Wonderfully put. I would want to invite Dr. Sunita's comments, especially when you talk about detachment, and especially since you're taking care of patients who may be terminally ill, you are into palliative care. So, Madam, what are your views about self-preservation, and how do you practice detachment, especially when you lose a patient and then you have to go back, as Dr. Renu mentioned, to home, and then your responsibilities change. So how do you manage that, and what is your opinion? How should doctors manage such similar situations?
Yeah, so it's interesting. Like when we see in palliative care, mostly our patients are either very sick with serious illness or they are towards the end of life. And when we try to deal with them, it's not just the patient, you have the family, the caregivers, everything comes with it. And when we come as a provider, I think the way we are trained in medical school, I think we are never taught how to be vulnerable. We are taught to be fixing everything because we focus on a disease-specific model for the health. It should be the whole person. That means the person with not just the physical and mental health needs, but they also have the emotional needs and spiritual needs. I think that misses when we are trained. So we go with the mentality that I'm supposed to be able to fix everything. And then we find ourselves in a very hard spot that I cannot fix it. And then it causes a lot of moral distress just to a physician, or if you are working in a team, then team has a lot of distress and they get very dysfunctional. So that is one aspect of it. The second aspect of it, like the conflict can be between the individuals, you as a person versus the family, you as a person versus your team, or you within yourself. Because sometimes what they are choosing, I may not like it, or what they are doing, it can become very hard to navigate through that. And in day-to-day patient interactions, it is so fast-paced that we don't even realize our own emotions, and we start kind of getting detached during the patient encounter, and we lose the patients and the family, and they start getting upset. So the one thing that what the palliative care training does, one aspect of the training is like how to identify the moral distress and know that it is coming there, and how to be aware of it during the interaction with the patient or whoever is that person, either a specialist or ICU person. And when you become aware of that, how do you reset yourself during that conversation? And it sounds very hard, but once we start focusing on it and practicing it, it becomes very hard. It becomes very easy, because then you can reset yourself and you are always in the present, because the only time we can connect to the patient or anybody is when emotionally we are stable. And most of the times the tools that we will do in these conversations, somebody is dying or somebody just died, or we have to give them a very serious news. Usually I take 1 or 2 seconds when the patient is trying to tell something. I will sit back and I'll say, what am I feeling inside? What are my emotions? Am I just trying to run away from this conversation, or am I going to be there to help this person? So it comes to basically, I put it like in 3 things. like the simplicity, that's just what the human connection is. Simplicity, being like compassionate, and be there, that is connectedness. Simplicity means I just figure it out. What am I feeling? Why are my emotions like this? And then we have to connect to the patient. And then compassionate means I get myself to a point that I don't have to fix everything, the pain that is here. And I can be just with this person during this pain without giving any solutions to this person, because we directly jump on to giving the solutions. Okay, we can fix it this way, whatever the topic is. But then we lose that connection, that time to be there, because patients many times will say that you don't understand. Well, we really don't understand because we are not in their shoe. So if we take a pause and we can just be with them and articulate them, that I can just imagine, it just opens up the whole different emotional box. But then you also at the end feel kind of, okay, I did something to connect to this person. I couldn't solve the problem, but at least I am with this person. And I think I try to train myself, but we try to train our staff, because we work in big team settings, because a lot of people burn out at a lot of different rates. And then that's what I think basically everybody should be trained right from the beginning in the med school, because this is where we start struggling as we go out in the real practice. That's what I feel will be the simplest tool.
Yeah. Very well said, ma'am. Two movies come to my mind, and they are my personal favorites. One is Patch Adam, and the other is Munna Bhai MBBS. When you talked about emotional connection with the patient, I think those two movies really bring it out. You mentioned team, and I would like to invite Dr. Shailendra's comments, and I know he mentioned about teamwork as well for self-preservation, because there is a shared responsibility amongst the teamwork, and we all know that team stands for together, each achieves more. So what are your views, Dr. Shailendra, about self-preservation? How do you practice it? Do you have a team? And maybe you can give us some examples about, since you are a pediatric endocrinologist, how does a teamwork help in a child with childhood obesity or with type 1 diabetes, the educators, the everything which is so important in, especially in education, not just the patient, but the extended family members as well.
I think, listening to Bajaj Madam, Dr. Renu and Dr. Sunita, my take on self-preservation, that is, I think, empathy, compassion, they are built into our profession, and the work pressures, as Dr. Bajaj mentioned, and that imbalance of physical, spiritual, and emotional integrity because of pressures, from within the profession and outside the profession in our social life. They create that imbalance and lead to the burnout. And Dr. Renu mentioned about few tactics, how we can self-preserve by detaching ourselves and investing in our hobbies and investing in other things, taking breaks time to time, in order to try and create that balance. And but coming specifically onto the teamwork, and it's a very good point that most of us, we work within the teams, and it is important to look after the team as well, and so that the team looks after you, and that creating that seamless interaction between the team, the individual, and the families who you're working with, because the families are an integral part of the team. So giving an example, for example, as you mentioned, the type 1 diabetes, suppose a child is coming in severe DKA, in a very dire state, very sick. And this is the first presentation, which is usually the case in the DKA children, that family has no idea about diabetes or how it might have happened. What they see is just the child is in a bed and is very sickly, and all the possibility come into place that what is going to happen. The fear of untoward, something untoward happening, and in that it's a very high flying situation. Everybody is busy. The team is busy in resuscitating the child, doing things, putting cannulas, preparing nursing staff, preparing medicines. And it's a very, time is flying very quickly. And you can see the numbers on the screens that, the heart rate is going up or going down, blood pressure, all those things, which is quite, for families, it's quite scary, scene. And most of them families are present during those resuscitation. And it is important that time, I feel, that team to think about how you manage that situation, how you prioritize things. Okay, the medical aspect of it is very important. You need to, make sure you take the right decisions, right clinical decisions. But at the same time, it is also important to liaise with the family. You, within the team, obviously, should think about assigning one person who is liaising with the family and talking to them, updating them time to time, and reassuring them that what is going well and what we want to achieve. So from that point of view, it is important that everyone within the team with each other, including the family. And also, when the things have gone well or when the things have not gone well, it is important to debrief before the event or after the event, and which helps people or the individuals to understand the dynamics and the reasons how things have gone well or not so well, and what to learn from them. And that de-stresses the people as well, because onus is not onto the one person being on the blame game. It just, everyone is pitching in, everyone is giving their own input, and everyone supporting or helping each other making the right clinical decisions. And that is also one of the part of de-stressing the individuals, because it is the team which is working, not just one individual. And there are a lot of education about that. Obviously in Western worlds, I've seen in UK, there's a very big emphasis on the team working and debriefing before and after the event. And also when you're working when the team gels with each other, when you understand each other in the team, you support each other, you are able to prioritize things better way, and you're able to take break in between as well. Especially, for example, another example, you're working in a busy ITU shift where a lot of sick patients, one after the other, you work on long shifts. And it is important to take time off in between, because otherwise the burnout will happen very quickly. You will not even realize that your body, you get so much physical stress and mental stress that your ability to take important clinical decisions is sometimes vague. So that is where the role of the team comes. And I think if we give a little bit of thought or a little bit of debriefing about how to prepare for those stressful days, and after that event has passed, how well you did and how you can make the change for the next event for yourself to be prepared.
Yeah, I think that is very well said. Teamwork is very important. Shared responsibilities gives you time to recover, because there is another person. It's like you pass on the baton to somebody else, and then he's running the next 100 meters, you take rest, which is very, very important. Short breaks are important. Bina, if you're there, there's a watch which says that we have 8 minutes left. Does that mean that we have 8 minutes to the present panel discussion?
That's true.
Okay, so we go on to the next question.
Yes.
Which is very, very important.
Dr. Sarita wants to probably comment because
yes, ma'am.
This was because Dr. Shailendra was talking as a pediatric endocrinologist. So I just, like if it's a type 1 diabetic, so you have a team in place, to explain that, yes, because even if it's for congenital hypothyroidism or juvenile, it's lifelong replacement, which is any day much simpler and can be easily done on a one-to-one basis. But how do you broach that topic? Because, giving lifelong insulin to a type 1, and then that question of self-preservation, I think it's extremely important from the endocrinology perspective.
Yeah, I think the way the system works is that, or the team works in that situation, is that whenever a type 1 diabetes, whenever there's a new diagnosis of type 1, there's a lot of education goes on for the family, and there's a well-built team which includes obviously doctor, diabetes specialist nurse, a dietitian, and a psychologist as well, because that psychologist here is for the child, for themselves, for child and the family, for themselves to be prepared for what is coming next and how they are going to cope with this lifelong pressure. And this format, obviously, after the initial admission, the whole emphasis is not on because these children are relatively stable, from medical point of view, once they are started on insulin. But the question is, how long they will be able to cope with that pressure of taking insulin injections on the daily basis, interacting with the dietitian on weekly or fortnight basis, and how they are going to cope with those pressures. So that is where the role of the team comes. So they are not seeing just one individual; they are seeing maybe 5 individuals within the team, taking turns, re-emphasizing the diabetes education, as well as preparing them to be able to come out of that denial of that diagnosis and come out to giving the good examples as well, how people successfully living their life with the type 1 diabetes, and how it is important to look after it appropriately. With a obviously you show a bit of empathy there. You show that you there to care for them. You are going to be in contact with them as long as they are with you.
So, yeah. So I think we have 5 minutes left. So 1 minute each. We'll have one question, same question to everybody. 1 minute. How does knowing your patient well help you in managing the patient? Decide is the managing strategies, and does it help in compliance and, of course, better follow-up and better outcomes? So I think we'll start with, and we just have about 5 minutes, so 1 minute each. We'll start with Professor Dr. Sarita Bajaj, and then we'll go to Dr. Renu, Dr. Sunita, and Dr. Shailendra after that.
Yeah, thank you, Sandeep, for that question. You see, it's how much rapport you are able to build with your patient, no matter how brief the time available. If the length of the time that you have to interact is not important. So I know that these are the 5, 6, 7, depending on the type of disorder, the messages that I need to convey. So I need to keep the age of the patient in mind. Yes, sex also, yes, decides. If, at least in India, if I'm addressing a woman, I will make sure that there is somebody with her. So, like at least from the rural background, I would feel that she's not able to comprehend, or what I convey will not be implemented. Because whatever I convey, if it's not followed, it doesn't serve its purpose. So to make sure the patient understands. So I've said the age matters, the sex is taken into consideration. Of course, the level of education, that's extremely important. The compliance will come positively if you're able to explain, which again, you need time to be able to tell, this is for this medicine is for this, because they would just go to the chemist counter and they will say, okay, you give me this one, without even asking maybe what that drug is for, in case the doctor's not been able to convey it. So if they're aware that this is my sugar medicine, my blood pressure medicine, my cholesterol medicine, this is not to be disturbed. Okay, the vitamin may not, the calcium, the vitamin D, etc., etc. So that is crucial for the compliance part, and how far the patient is traveling. Of course, these days we are also seeing, we are doing teleconsults and all, but Before that, patients were traveling long distances. I remember, like, I've been so upset with the patient. See, why did you stop your medicine? But you don't know, there was a flood in my village. I had to travel 90 kilometers all round to reach you. I said, good God, at least this patient has come to, like, show me, taken so much trouble. They value your opinion. And if you've developed a good rapport, the minute they sit down, doctor, I'm sorry, I wasn't able to do this because of this reason. So everything is in place. It makes it's so much easier if you've sort of done all the right steps in the beginning.
Thank you, ma'am. Dr. Sunita, you spoke about asking open-ended questions so that they come out with answers which will give you wealth of knowledge of how to manage your treatment strategies. Can you say something about that? Please unmute yourself.
Unmute, Dr. Sunita.
I think when it comes to the disease, like we have to always explore like what our patients thought, beliefs, and limitations, because that's where it comes. And many times they are afraid to tell, I can't afford it or I cannot do it. So I just open up a very broad question like, how does this disease affect you personally and in your family life? Because then they start giving us all the possible scenarios. So that also in a short period of time, you can get a lot of information. Or how does this affect your day-to-day life? Because sometimes they may not walk, they cannot do anything. So I think when we leave the open-ended question, whatever is important to them, they talk rather than we giving the one single pointed question. So basically it's we have to, I try to explore like what are their thoughts, beliefs, and how it is impacting their personal and family life.
Very well said. I am now acting like a news anchor. 30 seconds to Dr. Renu and Dr. Shailendra. So each has 1 minute each. So Bina, please give us a little more time.
Of course.
Yes, Dr. Renu.
All right. I think, if once a new patient comes, we try to gather their medical history, but I think understanding their social history, where they're coming from, what is their background, what their cultural beliefs or healthcare beliefs are, what their financial limitations are, can definitely help us lay out a better plan that can be individualized. We can cater to their needs. It's usually said that disease is a manifestation of their underlying status. And if we do not understand that status, there is no way we can cater to those fine details, and we cannot understand why they're not following certain recommendations that are coming from us. So that's briefly moving on to Dr. Shailendra.
Okay, I think, with all said so far, one thing I will add that we should all have a curiosity to know about the patient, and that is what it's about, how well you know the patient. And the way you do it basically is interlinked with empathy. Okay, I will say the acronym empathy. E stands for eye contact. So you need to be at the eye level of the patient and, talk to him facing the patient at the same level. Whether it's a child, you go down, you crouch down and come at the child's eye level. So that is very important. Second thing, M stands for muscles of facial expression. So you need to understand whether, patient has fear, patient is sad, you need to pick on that. You need to, be able to read that. Third is posture, what your posture is and what the, patient's posture is. So posture tells you a lot about everything, how defensive or scared you are. Then is affect. Affect means we all know what affect is, how you react to those emotional reactions, what the patient is displaying to you. And around your, surrounding the patient. Then comes the T for tone. What's the patient's, tone of the voice is? What's your tone of the voice is? So this, I think 2 more left, H and Y. So I don't know. H is hearing. So you hear out the patient well. What they want to say. You need to understand what they're trying to say to you. And why is obviously the first thing I started with the curiosity. You should have that curiosity in your mind, why this patient is, or what this patient wants from me, and why this patient is saying these this narrative. So I think that is where I will end my comments, that it's empathy which is the core of everything.
Very well said. It was a wonderful discussion. Thank you all. I'm sure our audiences would have gained something. There's some points to take home. Young doctors, if they're listening, they would have got some insights into self-preservation and some quick points given by Professor Dr. Sarita Bajaj of in a busy OPD, how to get to know your patients. Thank you very much. Once again, going back to Dr. Beena, again, thanking you for giving us this opportunity and wish you all the best to everybody. Take care.
Thank you.
so
Beena.
much.
Thank you very much.
Thank you.
Lovely being part of this panel.
Thank you, Dr.
Bye-bye, Sunita, Renu, and
Thank
Sandeep.
you.
Great anchor. Great anchor. Dr. Shelley.
Thank you so much.